So I would like to invite Professor Shi Yiming, former director of the General Surgery Division at TVGH. Welcome. Professor Shi will share his expertise on the robotic Whipple operation for the pancreas cancer. Yes. Next slide, right? So you're gonna use the.
And good afternoon, and
Good afternoon.
Good afternoon,
Good afternoon.
ladies and gentlemen. It's my pleasure and honor on behalf of our pancreatic team here to share with you our experience in minimally invasive pancreaticoduodenectomy (MIPD) from open to robotic approach. This is my outline. We all know that Whipple operation has been one of the most challenging abdominal procedure. This procedure is very complicated, involve a very complex and tedious surgical procedure. It always carry about 30 to 50 person mobility. And the POPF, the post-operative pancreatic fistula, is around 10 to 20%, and which has been the leading cause of post-operative morbidity and mortality. From the picture, you can see the traditional wound. Traditionally, the Whipple operation is carried out by open approach, and you can see the wound is not only big, but also ugly. And moreover, it is painful. It's a torture to patient. This slide will tell you what most of the patient prefer. The RPD means robotic pancreaticoduodenectomy. RPD can provide patient with better cosmesis and less wound pain with a smaller incision. And from the video clips, you can see all of the RPD can perform all of the surgical procedure done by the open approach. And RPD can even do better in Cochlear maneuver and also the suturing reconstruction. MIPD is actually include the robotic and laparoscopic approach, and how to choose robotic or laparoscopic approach in the so complex Whipple procedure. And these two video clips will tell you will tell which one is better. On the left-hand side, you can see the vision by magnified robotic scope is much stable. And on the right-hand side, the laparoscope is not so stable. And for the destruction part during the Whipple operation, I think the skillful laparoscopic surgeon can do also nearly the same procedure in the destruction part. you can see the vision is very, very stable. Both of these, both of these two video clips were performed by our very skillful surgeon. With the articulated robotic instrument, the median operation time is 7.5, which is much lower than that 11 hours by laparoscopic approach. Laparoscopic approach feel like a torture to surgeon. It takes a very, very long time from morning to at night, even after 8, even 11 hours at night. The RPD also has a lower POPF rate, pancreatic fistula rate for the soft and the non-dilated pancreatic duct patients. One of the major concerns is the cost in the RPD. You can see by our statistic, you can see the cost in the RPD group is almost double that of the LPD. That's a major concern to spread robotic technique for the Hui-Po operation. Again, this slide will tell you some benefit in the RPD. RPD is not only good for patient, but also for surgeon. For patient, as I mentioned in our previous slide, the RPD can provide smaller wound, and also you can see even scarless on this picture. This picture was taken 5 years after the Hui-Po operation. Even we cannot tell the wound are on the abdomen. It is amazing. So far, up to this week, we have performed near 800 cases of RPD. I think the number will be the top 2 or even the top 1 in the world, excluding the mainland China. We initiated our RPD program 10 years ago, 2014. And you can see from this bar chart, the total number of the Hui-Po operation, not only the robotic, has been increasing. And I expect up to the end of this year, our total Hui-Po operation number will be more than 200. And the number will be the top 1 in the Taiwan. That means robotic approach for the Hui-Po operation attract more and more patients in Taiwan come to our hospital. This is a robotic Hui-Po operation OR setting. The robotic machine can come either from right side or the left side, depends on the OR room. And this picture shows you how we design the trocar port. Briefly, the robotic trocar port are placed along a concave with the center on the umbilicus. First, we make a mini laparotomy through the umbilicus to check the abdominal condition. If it is suitable for robotic Hui-Po operation, we will do more trocar. And if you are interested in this trocar port design, you can check our paper just by typing robotic pancreaticoduodenectomy on the Google. You will find our paper on the top 1, and you can find the trocar port design. And the goal to check the detailed trocar port design. How about the safety in the RPD? Because the minimal MIPD works inside a cross at a very limited abdominal cavity. It is not easy to do the major operation like the WIPO operation. This video clip will show you how we do a very advanced WIPO operation. We called it WIPO at the splenic artery. Not only just divide the pancreas neck above the splenic vein, we do more, we cut more tissue on the body at the level of the splenic artery. By robotic approach, we still can do very radical dissection, skeletonize the vessel, like the pictures show here. This is splenic artery, this is a divided neck, and SMV portal vein. And here we will show you how we do the pancreatic reconstruction by modified Brungat technique. This technique is easy to do, easy to teach, and also easy to learn. This is our standard technique in pancreatic reconstruction. You can see with the articulated instrument, pancreatic reconstruction is much easier than the laparoscopic approach. Nearly all the same in open approach. Usually, it takes less than 30 minutes to complete the pancreatic reconstruction. Not only the standard WIPO operation, we also can do challenge vascular resection and reconstruction with pure robotic approach. If the vascular encasement is less than 2 centimeters, we can try that. It is very dangerous and risky. I think it is very, very difficult to perform under the laparoscopic approach. You must be very careful, and the bedside surgeon is also must be competent in case of emergency. We usually instead want to try the robotic resection and the reconstruction with a long segment vascular encasement. Under robotic surgery, there is no tactile feedback, so you have to use your eye to judge the tension on the suture. It is very difficult and need experience. Okay, this is pancreas cancer. And what the other benefit by robotic approach in WIPO operation? The constant finding is the minimal minimal blood loss. Usually in the traditional open approach, the blood loss is around 500, but in robotic approach, it is between 120, and even no blood loss in 6 cases of our RPD patient. In the past, by open approach, the delayed gastric emptying is one of the major, the top complication. Although it will recover eventually, but it will prolong the hospital stay and increase the hospital costs. But in our RPD group, it is a very surprise to me to find the delayed gastric emptying is very low, usually lower than 2%. And now we do not place NG tube after whip operation, even it is a very big, major operation. Now, no NG tube. The length stay is also shorter than the open approach. Surgical complication is also low in the RPD group. And how about the oncologic survival outcome? In our study, we published many papers regarding the RPD, and the lymph node yield, the lymph node harvest number is always higher than that by OPD. I think one of the reasons is we use magnified vision of the robotic scope to dissect the tissue around the vessel. Subconsciously, we will do more radical dissection during the RPD procedure. We did a PSM study. Before the PSM, the survival outcome is better in the RPD group. And even there is a trend toward better in the RPD group. This video clips is always my conclusion. You can see after the RPD patient, even in the old lady, RPD can provide easy ambulation on the day 1 and early ambulation on the day 1 and easy ambulation on the day 3, and even early and happy discharge 6 days after operation. It is amazing.
You done? You finished already?
Not.
Not yet?
Yeah.
Okay. Okay.
I don't know why
I think
the
the
slides is over.
technology problem, so
Okay.
excuses for that. Please continue.
Okay, then bye. Only 2 slides left. Okay. We also provide international service for our robotic surgery. And this patient is from Burma. And this patient is from Indonesia. They are very happy to receive the robotic whip operation at our hospital. And this slide is courtesy from an intuitive company. And the total number and the density of Da Vinci surgical system is the USA, and followed by the Japan. And in Taiwan, there are, I think now it is over 80 Da Vinci surgical system. And here in Vietnam, there are 5 robotic machines. And globally, the most common robotic surgery is gynecology and urology and general surgery. In Asia, the top 1 is urology, followed by gynecology and general surgery. And in Taiwan, also, the top 1 is urology and general gynecology and general surgery. Being a surgeon, I think most of the surgeon would say MIS shift the pain from patient to doctor, especially like for the old guy like me. But I lead a team. We successfully initiate the very difficult RPD. However, we all know that MIS is a worldwide trend. I has been encouraging our young generation be actively involved in the MIS surgery, even in a major operation like the hip operation. Thank you for your attention.